Thank you very much, everyone. Welcome. Chris Bain's my name. I'm the Professor of Practice in Digital Health at Monash Uni. Just bear with us as I share some slides with you and provide an introduction to today's session. Today's session is called Virtual Care, Virtually There, as we ask that question. It's the first in our series of ADAM deep dives this year. We're going to have 9 of these throughout the year, and I'll talk about a bit more about ADAM in a second. On the head of ADAM, which is the Alliance for Digital Health at Monash. Really great to have everyone online. I'd like to firstly acknowledge country. So I respectfully acknowledge the Wurundjeri people of the Kulin Nation, who are the traditional owners of the land I'm sitting on today in the northeast of Melbourne. I pay my respects to their elders, past, present, and emerging. For those of you from other places, we have people online and registered from multiple countries today. Certainly some Monash people, but a lot of people from outside Monash. I just wanted to give you a little bit of scene setting for Monash University. So we're one of the biggest universities in Australia. We're the only university with a faculty of IT and a medical faculty and a pharmacy faculty, which is really relevant when we're talking about digital health. We have a strong presence in Victoria. Everybody would know our Clayton campus. We also have campuses at Caulfield, Peninsula, Berwick and Parkville. We also have a presence at campus in Malaysia, a new campus in Indonesia, a facility in Prato in Italy, which if you ever get the chance to go to, please do. It's on the outskirts of Florence. It's lovely, very nice place to go. We have a permanent arrangement with sort of a combined program with Warwick in the UK. We have collaborations with Harbin University IT, with Southeast University in China, particularly through IT, and also through IT and engineering, a partnership with the Indian Institute of Technology in Bombay, which is located in Mumbai. And also I discovered recently a new centre there called the Koita Centre for Digital Health. So Monash generally, but particularly our IT and digital health interests, have a very broad footprint, is the point of all that. So a little bit more about this thing called ADAM. So the pandemic caused us to rethink a little how are we going to implement our strategies and ambitions in digital health. We're doing that through this alliance, which is the Voluntary Membership Alliance of Groups. And these groups certainly include many groups from within the bounds of Monash University across multiple areas, as you can see on the right of that slide. Different faculties, but also with our colleagues in various parts of the Malaysia campus and our colleagues at the Indonesia campus. Plus, we have a lot of membership groups outside of the university, so hospital departments, SMEs, and various others. And through those groups, individuals join. So the individuals within those groups who are most interested in digital health then join us in this alliance. And we have about 400 individuals across the Alliance. And you're going to hear from some of the Alliance members today, some of whom are permanent researchers, others are working in more an applied space as well. But all with this idea of virtual care and exploring just where we're up to with virtual care. Bear with me. Okay, so the reason for the 9 sessions I've mentioned is we have about 9 topics or focus areas. Now, we will work on anything, but we tend to focus on these areas. Equity through digital health, forensic informatics in partnership with the Victorian Institute of Forensic Medicine. Pharmacoinformatics is a new area for us. Extended reality for health, things like digital twins. Geron technology with multiple partners in Malaysia and Australia. Neurosciences and mental well-being, in no small part because the university also has strong capabilities in neurosciences and mental health. Cardiovascular health and well-being, as you would have seen recently, Monash has just opened first dedicated heart hospital in the Southern Hemisphere in a partnership with Monash Health, which is the largest healthcare provider in Victoria. electronic medical record optimization. How do we make the most of those systems and the data in them? But also this thing, what we've called the digitally enabled care models of the future. And that's really the underpinning theme of today's session. So a lot of those care models, which are digitally enabled, we also tend to call virtual care, and hence the topic for today's session. So I'm very soon going to pass over to our first speaker, but I just wanted to bring up their bios for your consideration. The first speaker today is Associate Professor Rashina Hoda from the Faculty of IT. Rashina is world-leading researcher, passionate about the people and process of software engineering. So this is a really important point. Our Faculty of IT covers everything from the deeply technical and multiple dimensions to the heavily social and human-centred aspects of IT. Rashina is an Associate Professor and Deputy Director of the Human Eyes Lab at Monash Uni in the faculty. Suzanne Baker is our second speaker. Suzanne leads the Digital Health and App Development Program at the Monash Centre for Health Research and Implementation, which is under the auspices of the Faculty of Medicine. Suzanne has over 15 years industry experience as a technical consultant and software development lead in companies ranging from startups to large global enterprises. And Suzanne's going to talk about some great work out of MICRI, as we call it, which was initially set up in collaboration with some of our IT researchers. Our subsequent speakers are Dr. Parry Dalir-Hagigi, also from the Faculty of IT. Parry is a senior lecturer in the Department of Human-Centered Computing and a member of the Immersive Analytics Research Group within the Faculty of IT. And she's also course director of the Masters of Information Technology. And I think Parry may even cover a couple of different kinds of projects that she's worked on very relevant to this space. And our final speaker will be Dr. Nick Naila Binti Abdullah, or Naila as her colleagues call her. Naila is a computer scientist and lecturer based in the IT school at Monash University in Malaysia. So that school shares its courses with the Faculty of IT here in Melbourne. Naila specialises in requirements engineering and multi-agent systems design. In her former role as a senior researcher at MIMOS Berhad, Malaysia's National Applied R&D Institute, she worked with external stakeholders to identify market opportunities and determine the right technology that can be brought into the market. And Naila has been working on a virtual care solution in the cardiac care space that she will talk about today. Just a bit of scene setting for today. So the speakers will each have 20 minutes, which I'll fairly strictly enforce. I'll make it clear to them if they're running out of time. If they have time within the 20 minutes, we can certainly have questions for them in the Q&A function of the webinar. Otherwise, we'll all come together for a panel in the last 25 minutes or so. So there'll be plenty of chance to discuss further and ask some questions then as well. So if you have any questions after today's event, I'll just hold this slide up for a minute. So rather than expose everybody else's emails, I'll expose my own. So if you have any follow-up questions that aren't covered today and you'd like them directed to any of our four speakers, or questions more general nature regarding Adam and our digital health work program, you can send them to me. Just make sure you put the .a in the middle there, because there's two Chris Bains at the university and the other gentleman won't be much interested in your emails, whereas I will be very interested. So just make a note of that. So with that, I'm going to stop screen sharing and hand over to Associate Professor Rashina Hoda, who's our first speaker.
Thanks, Chris. Thank you so much. Let me try and put my slides on. Okay. And sorry, just bear with me a second. It's always the share first or Zoom first. The background. So let me just, okay, let me share first. I think this should work. And then put it on full mode. All right, can people see a white screen that says for digital health perspectives, hopefully?
We can. Yes.
Awesome, thank you so much. All right, so thank you very much, Chris, for the kind introduction. I would also like to acknowledge the traditional owners of the land from which I present, which is the Wurundjeri and the Bunurong people of the Kulin Nation. And I pay my respects to the elders past, present, and emerging, and everyone else who is present here today. So I'll be sharing some of my reflections based on a specific project in digital health or virtual health that I've been dealing with, and that has actually led to a lot of learnings. So I'll be sharing some of those learnings with you, and happy to again discuss some of that in collaboration with my lovely panelists during the panel session. So what I'm about to share with you is based on 4 digital health perspectives that I have now figured that I have, which is, as a user, of course, I think there's almost everybody today that is a user of technology, and a lot of people are also users of the virtual health technologies, especially after COVID or since COVID, that we've all kind of warmed up to it, even if we weren't as warmed up to it at the beginning. The other is, of course, as a researcher. So Chris mentioned that at FIT here, we've got, so the faculty of IT here, we've got everyone from all the way to very, super technical stuff like program comprehension and analysis, meaning looking at really the code of the software engineering, all the way to the more human and social aspects. So that's certainly something that I do. Which is a little bit of both and especially the socio-technical bits where the two of them blend. And I'll give you some examples in a minute. The third one is as a designer of health applications. This is something I ventured into about 10 years ago with some student projects where we were looking at, all right, how can we build a mobile health app that people can keep track of, their health preferences and what they're doing with their everyday lives. So that was, really kind of testing waters. It wasn't the digital health scene wasn't as big at that point, but it really kind of started that journey for me where I was working with, again, different teams to come up with different design. And it's quite a different skill designing than it is to be a researcher, or the fourth one, which is a leader of a digital health project that I will share with you today. So I'm leading that digital health, CRC digital health project on enhancing telehealth. So I bring to you these 4 perspectives, and they quite blend in sometimes, I suppose. All right, so this is one of the slides I thought I'll bring up, which is how I view this whole digital health, what I call the iceberg, in that at first glance, if you look at the idea of digital or virtual health, it looks like it is a combination of, well, you take the healthcare systems as they exist, and you either digitize them or you add some kind of technology add-on to them, and there you have it. You have digital health. So that is the surface level view. Once you get an opportunity to dive deeper, what we find is there are a huge number of socio-technical aspects that need to be taken care of when we're designing solutions in this space. So just some of them include, for example, the lived experience of people who are going to be using these systems, what their needs are, what their wants are, which can be quite different from one and the other. Once you kind of have an understanding of what their needs and wants are, there's another thing to really look at the complexity of whether or not this is even technically feasible. If yes, how complex is it going to be? How much effort is it going to take? What are the licensing concerns of software? The privacy, security issues, obviously, there's ethics that plays into it, policies and laws, and all sorts of socio-technical aspects. So it really is an iceberg, and at the top, it looks pretty simple. But underneath, there's a whole bunch of socio-technical aspects that are going on. So the project that I was referring to leading is this one, which is the Digital Health CRC Enhancing Telehealth Project. And it is basically a project that runs across the organizations of Digital Health CRC, Monash University, Melbourne Uni. We've got Monash Health, Also, Health Direct Australia is our industry provider. Health Direct Australia, if you see the logo at the bottom, it doesn't ring a bell. Anytime you've actually used a virtual health consult with a doctor, it's probably on their platform. They're the largest provider in Australia. And of course, the Victorian Department of Health that we are working with. So this particular project, it focuses on two specific cohorts, which is the mental health and the palliative care cohort. And the project is fairly large. It's about $2 million for 2.5 years. And we're now into the second year of developing our digital health solutions after having researched and co-designed with those two cohorts. We also have a interdisciplinary R&D team, as you can imagine, with not only the technical people, but of course the medical experts, clinicians, and so on. Yeah, so this is the background on which I'm going to be drawing some of my learnings. Right, so I talked about socio-technical aspects, the stuff that was underneath in the iceberg. Another way to think about these aspects that I've discovered is to look at them from 3 different perspectives, and they do overlap. So when we're designing solutions in the digital health space, my experience says it kind of comes under 3 different banners. One is what it is that the users want, need, and they're willing to use, right? So it's all about understanding the user preferences. The second then is what can be designed and developed. So what is technically possible to do, right? And third then is what can be deployed and maintained. Now, all 3 of them can be very different things. But the idea then is all of the first one that I mentioned is really the human focused aspects. So the lived experience, the human aspects like the age and the gender and abilities of your users and so on, adoption barriers, things like that. The other one is implementation focused, so technical complexity, effort, software licensing, all of the other ones. And the third is released focused. So you might have a project where you do co-design and understand human focused aspects. You combine it with implementation focused aspects, but it may be a research prototype that you're not really interested in putting to market, in which case you might be happy with those 2 circles, and that's fine. But now you're wanting to put a digital health solution into the market, you also then need to consider that third circle there, which is the release focus. So what's the market demand for such a feature? What are current supplies, the trends? What are some of the adoption challenges and so on? So this is what I call really the real world digital health solution sweet spot, which is right in the middle, is when you have a kind of overlap of all of those happening together, is when you have kind of hit that sweet spot in terms of coming up with a solution that people are going to be willing to use, that is technically possible to implement, and finally that will actually be deployed into the real world. Cool. So I'm going to quickly go into some of the examples of how we can apply those socio-technical aspects and really trying to find that sweet spot. Okay, so the first one, which was the human focus aspect. So one of the things that we can do, and we've done, is to conduct like interviews in focus groups and co-design sessions with patients and clinicians. And the idea would be to capture things like, all right, what do you need? So a user might say, all right, I'm gonna need fast and secure connection. That's fine. And then you might ask, what do they want? So they might then also want things like, oh, it should be intuitive, user-friendly is a common term that comes up. I should be able to schedule my appointment. Perhaps even things like early diagnosis prediction is something that a user might suggest to you that they want. Then the user may also have concerns, and it's really important to capture these as well. So they may say, all right, it's really great to have this kind of stuff that you're suggesting, but what about my privacy of my data? Because this is very sensitive health information. So an outcome of this process, it would be to understand and to capture a list of user prioritized desirable features. And the reason you see that like Aladdin's lamp over there is it's really just a wish list. It's a big and fat, long, usually long list of things that they, everything you could ever desire in the best digital health solution out there. So you collect that list, which is perfectly fine and the right thing to do, and you prioritize it based on what the users want. However, remember now we have to marry that with the implementation focused stuff. So which is, what is the likelihood of actually implementing it? Now, that means we have to kind of look at this and assess the technical feasibility of these things. So we might be then looking at things like, well, users mentioned appointment scheduling, but guess what? That's already available in the market quite easily, maybe as a plugin, or the platform that we're dealing with already has appointment scheduling. So that's really not for our research team to look at. Then they might have suggested some things which are definitely cutting edge, but may not be within the remits of what you're trying to do in your research projects, or the funding for it, or the timeline for it. Early diagnosis prediction is an example. It's not to say it can't be done, definitely can be done. But here I'm giving an example as, say, for example, within that project context, it's not within scope because it's just, too complex and requires a much bigger team or whatever. So you might say, all right, sorry, but that's out of scope. Next, then you might say, okay, we also need a platform here, which is, say, for example, the web RTC platform, which is the web real-time communication, which is essentially the name for the underlying infrastructure based on which we have these virtual consult platforms for doctors and patients to connect with each other. It's highly unlikely that a user would have come up with that specific suggestion, but as a technical team, we know that we need that technical infrastructure established. So then you add on those technical requirements and dependencies on top of that. And the outcome of this process then is, remember we had that, really large list of everything wanted, desirable. Well, now we have a little bit of a smaller list, which is a user prioritized list, which is also technically feasible, right? So it has all the desirable but necessary features that the team is ready to look at. Okay, so far so good. We've got the two areas covered, which is the human focused and the implementation focused. And as I said, some of our many, in fact, research projects might work within this scope, which is perfectly fine. But sometimes we have the opportunity to work on something that can be released. And by that, I mean released into the real world with actual users on the real platform. So that brings in the third area, which is the release focused. So what can actually be deployed and maintained. And in this case, we'd be looking to, really look at stuff like, we have to kind of think at the market roadmap for that product, think about the commercial adoption challenges, and really discuss these things with the industry partners. So as a researcher, oftentimes this aren't the topmost things on our mind, like, what is the market for this, for instance, like research training to answer this question. But it becomes really important, something we have to upskill ourselves on very, very quickly to really understand the market as well. So here, for example, there might have been a feature idea that was the user wanted and is technically possible, but we find that the industry partner that you're working with already has that particular feature on their release roadmap, meaning they might be looking to release it in the next 6 months or in the next year, which is pointing to us to say, well, actually, it's a great idea, but it's already on their roadmap. So we're not going to invest our time and effort into building something that's already going to be built down the track. Next up, they might have come up with, talk about ideas that are unlikely to be taken up. So for example, the users or the patients in particular might have said, well, we actually want a recording of the entire, like a video recording of the entire consultation with my doctor. From the patient's perspective, fine, maybe that's what they want, but the clinicians might actually have a real concerns with this, and they would not be happy for all of their sessions to be recorded. So again, this goes to show things like, user wanted it, yes, it's technically possible, but nope, it's not going to be adopted because the clinicians are not going to buy into this. So again, that's probably something that might be discarded. And again, I'm just mentioning these ideas, doesn't mean this is discarded for good. It's just an example. It might be, brought on later on. and so on. So I'm just going to skip a few here in the interest of time and get to the fact that the result of this process, which is the final bit of filtering, if you like, is to come up with a user prioritized, technically feasible, and commercially viable list of desirable, necessary, and market-ready features. So that's where you bring all of those three things together. And then what you have is something you can develop as a health solution. So this is what we did in our digital health CRC project so far. And as I said, we're in the second year, so we actually now have a working prototype that we're evaluating with some of our cohort. So with that, I'm gonna move a little bit into introducing, again, in the interest of time, won't be getting into a lot of the details, but just to kind of introducing you to a method that is particularly suitable for studying and developing in the digital health space, and that is the socio-technical grounded theory method, which kind of people who may have heard of the grounded theory method comes from sociology, and it has been used widely in many areas to study social aspects. Now, what I've done here is through, around 15 years of practicing things in software engineering, studying software intensive systems, I've adapted the method into a customized one, which is called socio-technical grounded theory, and that allows for us to study domains that are not purely social, or phenomena that are not purely social, but socio-technical phenomena. And digital health certainly is one. As we've just seen with all the factors you have to consider, it definitely isn't just about the tech or just about the social aspects. It has to be a combination of social and technical areas. So this is the socio-technical grounded theory method. A preprint of this is available on my website for people who are interested. There are also a few technical briefings and talks. So again, unfortunately, not enough time to go into the details, but I'll briefly mention that it can be used to surface underlying socio-technical aspects that are relevant to the project. It can be used to better understand end users, what their needs, wants, and concerns are, to really understand the end user interaction and what their expectations are to do with like how they currently use technology and how they envision using it in the future. And it can lead to really evidence-based rich findings. And for those like especially researchers interested, you can also develop full-on sort of theories on these things. But essentially, it makes for a really nice way to study the problem space first before you jump into a solution mode, because that is, again, very common to do and is something that we should guard against. All right, so I'm going to do this skip. And let me see if I can make this a little bit. So finally, I'm going to kind of cover this bit, which is, so the socio-technical grounded theory, as I said, I'll be sharing the links at the end of the presentation, but briefly, the one also super key aspect of coming up with digital health solutions is the who do we need, which is the team. So this is where I think we definitely need a core R&D team. So the research and development team needs to have software engineering research and development experts on it. You don't just need the techies for developing the tech. You need the techies to understand the context in which the tech applies in the first place. So having them as the integral part of the team to begin with is really important. Then, of course, we need the medical and health experts. We need the healthcare practitioners. We need end users with their lived experience. Potentially, you could also have healthcare clinics who are ready to do evaluations for you, government support, industry partners, and whatnot. If you have a project that is particularly focused on ethics, for instance, then you might want to bring in ethics experts on the team as well. So an interdisciplinary team essentially is what we need. So I'm going to be sharing the 4 key takeaways, I suppose, that I said I had in terms of learnings from leading that particular project so far. And the first is that digital health really is a complex and interdisciplinary socio-technical domain. There's no two ways about it. It's not simple, it's not easy, and it certainly can't be done by only one set of people. The other is that designing a good digital health solution requires understanding and designing for the underlying socio-technical aspects. If we approach the problem as a health plus technology paradigm, it's not going to work. We have to dig deeper. Remember that iceberg, we have to dive deeper and look into the actual socio-technical aspects that make that problem. Third is a suggestion is to look into socio-technical grounded theory to really understand the problem space before we jump into designing solutions. And finally, as I just mentioned, we do need an interdisciplinary team with tech and health experts, but I should also say anyone else that's required, security, ethics, policy, and so on. So with that, and I can almost see Chris glaring from within his photo because I'm up to time. These are the two resources I will share with you. So on my website, rashina.com/STGT, there are a couple of videos that will give super quick introduction to STGT, as well as a free author preprint of the paper, and I'm done. So thank you very much.
Thank you, Rashina. And I'm sure Rashina is happy to mention a little more in the questions if people are interested about some of the specifics on our CRC project as well, without revealing everything under the hood. We will move on in the interest of time. Thanks again, Rashina. And I'll hand over now to our second speaker, who's Suzanne Baker from MICRI. Thanks, Suzanne.
Thanks, Chris. Just going to share my slides. There we go. Thanks, Chris. You had already introduced myself. I work at the Monash Center for Health Research and Implementation. And we have created a number of digital health apps and risk calculators that are being used internationally in over 180 countries by a growing number of users. And I'm working closely with researchers, patients, clinicians, and healthcare professionals to provide solutions that are relevant, engaging, and make an impact. That's what we're focusing on here. Our digital group is creating innovative and scalable digital health ecosystems that aim to improve the health outcomes for the community and provide personalized applications and decision support tools. As Rashina already touched on the huge area of digital health, which is extremely complex. It's to move into the future of health, we're leveraging the exponentially growing and ripe technologies and the expectations that users have on internet connectivity and the connectedness and the expectation of availability of data and information. And the options that we have in digital health, they're endless and they're growing. And there's telehealth, digital medicine, remote monitoring of our activities with all the devices that we're connected to, computational biostatistics. There's AI-assisted diagnosis and prediction, remote surgery, chatbots, and so many more, and they're growing every year. At the Monash Center for Research and Implementation, we are working on creating innovative solutions that have a real impact on the patient's health and well-being. And our researchers and clinicians are exploring new ways to use the digital health technologies to improve the healthcare access and quality and efficacy. And we're seeing some really exciting results. And I'm going to speak about the solutions we're providing in a little bit. What we're also facing, and Rashina mentioned that also with her iceberg, and I'm just pointing out some of the challenges for digital health here. that everyone working in IT and developing solutions is facing are the data privacy and security regulations. Obviously, they are really important for very private health data and sensitive information, and they must be properly protected, and unauthorized access must be avoided. The hospitals and healthcare providers have fragmented systems that are complex to link to and to upgrade. That is a challenge we're facing, and the tools do not always communicate with each other or effectively, there's also the challenge of slow and limited user adoption for innovation from health providers and potentially also patients. The cost of implementing and maintaining digital health technologies can be high, and it may not always be clear on how providers can be reimbursed by the healthcare providers or hospitals. There are ethical questions related to the patient's autonomy, the consent, the potential for bias and discrimination, and the use of health data. Access and equity is a big issue that we're handling here at the Monash Center for Health Research and Implementation. Digital health can improve healthcare access, but still it may also amplify existing disparities in access to healthcare and their outcomes, particularly for underserved populations who may lack the access to the necessary technologies or the digital literacy. What we also see is moving towards a personalized content is important to ensure that each patient receives the most effective and appropriate content and treatment and for their unique needs. And one size fits all doesn't take into account the individual differences in patients' genetics, the lifestyle, the cultural background, and other factors that can impact their health outcomes. And personalized care can help identify patients at risk for certain conditions and enable healthcare providers to tailor their treatment plans accordingly. Moving towards a personalized care is an important step towards the patient-centered care that addresses the individual needs. Algorithms and machine learning models can process a vast amount of data to identify patterns and predict risks or health outcomes, and that enables healthcare providers to intervene early with preventative measures. At MICRI, we have developed a number of such decision support tools that are currently live and predict those risks. One of the areas that we're making impact is the use of technologies to deliver evidence-based information and lifestyle interventions remotely. At MICRI, we focus on research translation and implementation. Through the research, we're exploring how digital care can help to overcome some of the challenges of traditional healthcare delivery. But we know that digital health is just one piece of the puzzle. We need to think about how digital technologies can be integrated into every aspect of life and healthcare delivery. What we're working on is innovative solutions that deliver evidence-based educational resources and lifestyle interventions to support and manage conditions. This is to improve the lifestyle, support the diagnosis for early interventions, but also empowers patients to take an active role in their own care. And that is only possible through collaborations and partnerships. And we're very fortunate to have those strong relations with healthcare providers, patients, other faculties at Monash, and other universities, and many stakeholders who help us guide through the research and translation. I would like to highlight some of our recent projects that showcase the importance of a human-centered design and the involvement of patients in the development. It's our Ask PCOS app and the Ask Early Menopause app. There are mobile health applications designed to improve the health and well-being of women with the conditions. At MIPRI, we have a patient-centered approach in developing our applications, and we work very closely with women with the conditions to ensure their needs and perspective are integrated into every stage of the development process. We're engaging with women as co-designers, and we're able to create apps that truly meet their needs and empower women to take control. We use a design thinking approach, which isn't always linear, but I get to that in a little bit. What we've created are progressive web apps, which are mobile apps that are delivered through a browser, which have some advantages that we've seen work for the users of our apps. They make the app accessible to a wider range of users, really regardless of the type of device or operating systems they use. We have the apps can be accessed via the browser, but they are also available in the app stores, which helps with the adoption and helps engaging users as well who've learned to search for apps on the app stores. It also allows us to update and maintain the apps and makes sure that that users always get the latest features and security updates. What we've used is the PWA Builder, which makes our progressive web apps available in the stores. It's an open source project that allows us to create an app bundle for existing URLs and load them in the app stores. We then still go through the normal approval process for each individual store. But we've really seen that helped us with our findability and the adoption of the app. And we get quite a lot of traffic through the stores. Our apps, they feature a range of tools and resources to help women manage their symptoms and improve their health outcomes. Our apps have a symptoms tracker that allows users to monitor their symptoms and identify patterns and triggers. It also includes evidence-based educational resources and a goal setting and tracking tool. And a feature that supports the communication between patient and healthcare provider. And we recently launched a discussion forum for both those apps to create a forum and a community for women with the conditions. It's by involving women in the design process, we created apps that are tailored for their needs and preferences. And we did listen to their feedback and incorporated all this in the design of the app. We also iterate the design, and you can see here a heat map that we use to analyze the data. We use quantitative and qualitative data. We also continue to do interviews and feedback rounds with women, and then prioritize the changes that we implement in the apps. That's an example of our human-centered approach, and patient engagement in the development of our digital health solutions. And they're now used in over 180 countries. And I'm excited about how the digital health can transform healthcare delivery and improve patient outcomes. As we've seen, and the topic of today's webinar is virtual care, are we virtually there? I think there are many enablers that enable digital health, and also some barriers that need to be overcome to create the solutions that are that can be delivered and implemented. But as technology continues to improve and more healthcare providers adopt virtual care, its use will become more widespread and accessible in the future. At MICRE, we have a number of exciting projects ongoing, and we're committed to advancing this field through our solutions, research, and partnerships, and translating knowledge into clinical practice and the health system. And we look forward to continuing and make an impact in the years to come. That leads me to the end of my presentation. Thanks, everyone, and I'm happy to answer questions at the end.
Thank you, Suzanne. Definitely looks like we've got time for a question if somebody wanted to pop one into the Q&A for Suzanne. Suzanne, just while people are thinking about that, how many downloads have there been roughly of Ask PCOS? Because I know it's been around a few years now.
We have 35,000 regular users. We implemented that symptoms tracking tool, and we have 1,500 that use it regularly. So that's the real engaged users that come every week and track their symptoms and really use this. We can analyze their patterns, and that really helps the communication with the health professional.
Yeah, excellent, excellent. So just people might have been able to pick up there, and you can see on Suzanne's slide there, there's a couple of apps in a series. The first one was for polycystic ovary syndrome, and the other one for early menopause. And a lot of this is because of a strong research team at MICRE about women's health, which has driven this.
And we have, I mentioned our risk calculators earlier in the personal GDM range. I didn't focus on those, but obviously they're also live and used in clinical practice.
Yes. So again, apps for gestational diabetes, just for people who are interested. You might want to look up MICRE or reach out to Suzanne afterwards. And I'll put my email contacts up again in case anybody needs reminding at the end. I can't see any questions in there, so that's okay. We can come back later for questions for Suzanne with the panel. Thanks again, Suzanne.
Thanks, Chris.
So with that, I'll hand over to our next speaker, who is Dr. Parry Dili-Hagigi. Over to you, please, Parry.
Thank you, Chris. Thank you. I just share my screen. Hey, hi, everyone. Thank you for joining us today. I also want to acknowledge the people of Wurundjeri on whose lands I am presenting today. I pay my respect to their elders, past and present. So I am Parry Dili-Hagigi, Senior Lecturer from Faculty of IT, and today I'm going to talk about my research areas, and a few research projects. Because of time, I can't talk about all of them, so I've selected a few, and then the conclusion. So my main research area is mobile computing that focuses on addressing challenges related to performing computation on mobile devices such as a mobile phone. And when we are dealing with mobile computing, of course, we are dealing with sensory data, multiple sensory data. And then another challenge would be how we aggregate these sensory data, do sensor fusion, and convert it into more meaningful, high-level information. And I have contributed to that area as well by introducing a fuzzy-based reasoning approach. Mobile ubiquitous computing over time evolved and kind of encouraged, motivated the IoT computing. And that I also work in developing IoT applications. And from that, another topic, edge computing, emerged, which means, and of course, an efficient way of doing computation to process and analyze data where it is close to where it's produced on the edge, and mobile phone itself could be the edge. So I focus on also doing that type of edge computing, which is very closely related to mobile AI, that enables us to train the deep learning or AI model offline, and then using existing technology easily, we can convert it into a mobile light version and run that model on the mobile phone. So I have worked in that area as well, because at the moment, any mobile app, smart, intelligent mobile app includes some kind of AI or deep learning model in it. As you see in the core, you see context awareness. What is that? So context awareness, it's the core, the key ingredient to all of these research areas that I work, and they are all linked and connected together, and context awareness is in common to all of that. What is context itself is any related useful information about an entity, could be the user, the device. It could be mostly is sensory data from external sensors, wearables, and sensors from the mobile phone itself. Also, it could be the GPS location information. It could be the information from public APIs that today we use in our mobile apps to get more context. With a few lines of code, we could get access to lots of information provided by service providers doing simple HTTP calls. Like on the app, I can get the temperature for my location. I can get the nearest park, restaurant, hospital, pharmacies to my location. I can get the nutrition values of what I'm eating right now. And so that's why it makes context awareness also important to all this. And I work in that area as well. Then all my skills and experience from these areas, I apply to different domains. And one of them, of course, is healthcare, one of the main areas. And mostly for chronic conditions. And these chronic conditions I have listed here today. I'm only going to focus on low back pain, but the last two, fibromyalgia and rheumatoid arthritis that I have worked mostly works with social media data. Social media data is another source of context that I use. It's a different type of data. So we have physical sensors, and social media is our social sensors. We could totally get different data from Twitters about what people think, feel, and their beliefs, perceptions. And that's also important. And we can do lots of different types of analysis with that. Diabetes, I am right now working on a project in collaboration with Eastern Health, and hopefully soon I can talk about it in another event. But for today, I'm going to talk about low back pain, my projects on that. So low back pain, I guess all of us have experienced it one way or another. It's one of the leading causes of disability in the world. It's a big economic burden. In Australia, 1 in 6 suffer from some kind of different types of back pain, and these people are mostly aged 45 to 64. And some of the key research problems in this domain is treatments are limited, and that's why people turn into painkillers and narcotics. That creates its own problem. The other problem is the use of one-size-fits-all approach in outcome measures, that I'm going to talk more about that. So the motivation for these 3 research projects that I'm presenting is considering the risk factors of low back pain. One of the major one is physical activity. And with access to smartphones, sensing technology, we can easily capture that data and do more research on also understanding the relationship between pain and physical activity. And by doing that, we could help the people with better managing of their pain. And for also availability of machine learning, deep learning models out there to help us with the detection. So 3 projects. I start with the first project, mobile data collection. This was collecting pain and function data here, physical activity data. And this was in collaboration with Alfred. It was a PhD project that has been completed. So in this project, the background is that in clinical studies using traditional gold standard measures, you have two time point approach. So you collect the data at baseline, you collect it at the end, and what happens between. So that's not captures. And between these points, individual could experience changes in their pain level, physical activity level. And this might be a reason that in some of the clinical trials and studies, those interventions and treatments that they are testing at the end, they cannot find, they don't find them very effective. Could be one of the reasons for that. So we wanted to see how the smartphone-based data collection could address this challenge, could complement. We are not trying to replace traditional standard measures. We want to try to complement them with more useful data. And this type of data collection also is referred to ecological momentary assessment, EMA, that has become very popular in the digital and mobile healthcare. So it enables us to collect the data more frequently. We use mobile phones. In mobile phone, there are many sensors. We can collect more than 100 different types of data. But in this one, we were interested in just about understanding the physical activity at a little bit high level, like sitting, walking. And based on the feedback from experts, we only focused on sitting and walking, although we could determine other activities, but we limited to these 2. And also we were getting the pain intensity information, and based on, again, our expert feedback, we every day at the fixed time, it had to be a fixed time every day, we were asking, what is your current pain? What is your maximum and average pain in the last 24 hours? And physical activity data was collected automatically with our app that we have created in the background, so user didn't need to do anything. The only thing we asked them for 2 weeks to carry a secondary phone we gave to them around like a belt in a pouch, in the best location we could have high accuracy of that. And then we conducted a series of analysis, and what you can see, the graph here is just kind of 2 of these results. it shows the correlation test that we ran to understand the relationship between pain and walking duration. And for the whole population, we found significant negative relationship between pain and walking, which kind of it's what we expected. But we couldn't find any significant correlation between pain index and sitting index. But when we looked at both sitting and walking to the individual data, they were very, very different. And so as our finding, we can say, yes, we noticed that when we collected data frequently, there is considerable individual variation and fluctuation over those 2 points that traditional measures collect, and it can be captured. And also this type of mobile data collection could enable us to do also investigation of understanding the interrelationships between these measures. And as a result, it contributes to more personalized, multidimensional approach to the assessment of outcomes. In our second project, which included a PhD study, again finished, and a MIND project that also has completed, again in collaboration with Alfred, and also Monash Engineering because of the sensors we use. So in this study, we didn't focus on the physical activity like sitting and walking. We wanted to have a more granular view of detection of the movements, which is very specific lumbopelvic movements, and listed here 5 of them, like flexion, extension, rotation. Our aim was to use a very novel sensor, e-skin sensor, which is like a Band-Aid, very stretchy, comfortable sensor. And we wanted to see if we can use that for detecting these lumbopelvic movements, which could have been used for out-of-hospital monitoring and using, on just the mobile phone to detect it. And detecting it, why is important? Because when clinicians and health professionals want to assess you, these understanding, identifying, assessing these movements could help them with identifying functional limitations and physical predictors of low back pain. That's why it was important. So these sensors that you see, the black one, are e-skin sensors. And these are the sensors that can only sense the stretch of skin. So the data we could collect is a stretch of skin. And based on that, we wanted to detect whether the person is doing rotation, flexion. So how we do that? It's it's between the number of steps that we have to do. One was we will use the gold standard wide mode sensors, that it's commercialized sensor, is clinically validated, and its job is to detect these movements. So that was our gold standard there. So we could use it along our sensors and get the data and see if we could create some kind of algorithm for mapping. And after that, we are able just to remove the move and use that model for detection, just using e-skin sensors. I just show you some of the results of, there were a number of series of experiments. Because of time, I can't go through all of it, that our PhD student, Yuxing Zhang, has conducted it with in collaboration with Monash Engineering team. And as you see in these experiments, the blue line is the data coming from Y-move, and the data coming from the e-skin has a very nice, obvious pattern. And that enabled us to create these type of mapping algorithm and use it for detection just using the e-skin. But of course, there were challenges and lots of experiment with calibration, validation, and also finding the right place to wear the sensors, because the location of the sensor at the back is so important. And just to find the right location, it also requires lots of experiments. So the last study is a little bit different because it's not using physical sensors, it's using the social sensors, Twitter. And this was also in collaboration with our team from Alfred. So in this study, we looked at the traditional qualitative studies, the interviews, for example, that usually happening in that space. And they always have to focus on a single topic, limited, fixed number of questions, and those kind of limitations that we can address it with using the social media data, that people freely can express their feelings, opinions, and we can collect it from larger population, distributed population, and it's all free person data that in the social media, of course, using the proper filtering and all that. So our aim was to see if we can get what people think, believe, using this social media data, the contextual variables of low back pain experience. And our results showed a number of topics that with the help of our expert, they labeled it and merged it into 19 categories, as you see here. The largest one was emotion and beliefs, then physical activity, and the smallest one you see was food and drink, and one interesting one not being understood. And then what we did, we matched all that to the existing literature to see which areas are under research. And most of them pretty much, they were aligned with the literature, but there were some that haven't been addressed in the literature. So the results was telling us that such data can complement conventional qualitative studies by providing first-person perspective. And also that could help healthcare providers and clinicians with developing more personalized and effective therapies for low back pain. So as conclusion, which is pretty much lessons learned, what I have here also to answering, are we virtually there? We are on our way to virtually there, but still there are many open issues. Today, I only maybe mentioned the ones related to these three projects. So regarding the sensors, using innovative sensing technologies like e-skin is great, new capabilities for monitoring, new ways of collecting data, but requires a lot of work, experiments, to get to a point that is reliable. Using commercialized sensor, well, they are validated reliable, but we have tried a few times. The problem is that with them, they come with their own software and mobile app, so we are not allowed to access as an open API their raw data in real time, and that's a challenge. One other thing, so where to go from here, somewhere between, but also another space I'm looking into it is just using a smartphone for sensing. Of course, it is not going to be like wearables that can provide us lots of other data for example, for low back pain movements, but a smartphone and getting advanced every day, they provide lots of data. And I have another project we finished, and we are there's lots of information there that we can use to learn about the daily activities. And then about deep learning, mobile AI that we're running on the mobile phone. Yes, they are great, powerful, and accurate, but we have learned other thing that We start with user studies with limited number of participants, and the amount of data for deep learning is it requires lots of data. So what to do with that? Well, there are now some research happening in the data augmentations methods, even in healthcare data, sensory data. That's a place to look into it to address this challenge. The other problem in this domain is how we retain app users. Okay, we create great app, we can monitor the user for self-management, but we have realized that in our studies, even it's hard for 2 weeks, we keep the people carrying the phone, secondary phone, or the wearable, wear it, or even like with the diabetes, wearing that patches for glucose monitoring that has micro needles. And we tried even in my own family, and really 2 weeks. I know people wearing it for years, but I'm just saying that, yeah, these are the things to look at, it, how we can make it easy for people. And some related topics to that is the last point that I think previous speakers also highlighted, that I think everyone is highlighting it related to digital health, is personalized care. So how we can create innovative mobile solutions that works really well, and we can have high retention of users. So by involving these people in the design and development of these solutions, using co-design, participatory methodologies, and to make sure that we are creating a solution for the people who are really going to use it. So that ends my talk for today. Thank you, everyone.
Thank you very much, Barry. Spot on timing, spot on timing. So we won't pause for a question now. I'll just draw the attention of our speakers to a couple of questions that are building up in the Q&A panel. There's one that's been a little moved about how do you involve non-English speakers, the artsy community in co-design, but we'll come back to the questions later. Just a note for my colleagues from AIMS Jammu, it's wonderful to see you online. For those who don't know, AIMS Jammu is in the north of India, nearly at the Pakistan border. I see your hand is up. If you have a question, please just type the question into the Q&A. But I shall now hand over to our last speaker. That's the wonderful Dr. Nick Naylor, who's going to tell you about her project she's very passionate about. So over to you, Naylor.
Oops, unmute. Thank you. So let me time myself at the same time. All right. So thanks, Chris, for the introduction. My name is Naila, and I'm going to share a slightly different story here. Our journey in Malaysia, in emerging market, from translational research to setting up Green's Heart, a digital health startup in Malaysia at the Monash University, Malaysia. So before I go further to sharing the joy and the challenges, there is a significant meaning to Green Heart. So for us, we imagine, we know greenhouse is an environmental control plate to grow plants constructed in any place in the world. And a strong heart from a medical perspective is having a healthy heart, and from our philosophical perspective, a heart that acts with kindness to contribute to society. So inspired by and blending this idea, Green Heart uses AI technology to bring people together to facilitate learning, medical advances, and improve patient outcome. So we really believe that anything we want to do in benefiting society and economy is possible, even in a country with limited resources, if we start with a strong heart in a greenhouse. So that's the story. Now, I will speak about who we are. What was it that we wanted to build, which was actually 11 years ago. It was very hard because digital health was not known as a discipline yet. What we have done and actually built since 2019, what we've learned and what's next. So I come from a multidisciplinary background. I think my strongest skills is actually requirements engineering. And I was very excited listening to Rashida because we do apply socio-technical perspective very much in our project. And I met my co-founder, David, who was the person actually, he was the former vice president for Medtronic for the heart failure business. And he managed 1.5 billion USD portfolio for Medtronic. It was the 1.5 billion USD revenue generated for Medtronic during his time. And I was the co-chairman. We organized Frontiers in Intelligent Medicine. Back then, Chris Bain wasn't yet at Monash University, Australia, as a digital health professor. So that is how I met David Steinhaus. We invited him as a speaker. We had a working group session. So it was really, exactly what Rashida shared with us about her methods. We had a working group where different stakeholders, industry, policymakers, software engineers, scientists came and had a team. And that's how we discovered this project. And he was the one who told us, like, hey, Naila, what you're doing is meeting the unmet need of emerging markets. And that's how he got on board. And we founded this startup in 2022. And it's exactly what Rashida said. How do we sustain? We have to make a business out of it if we really want to translate and improve patient outcome. So this is our scientist team and cardiologist team. So there's a little bit of history here why I'm working with this team in IHMC. It's all because of William J. Clancy. He was my PhD examiner. My PhD was in multi-agent systems, specifically in using FIPA and KQML language to make software agents able to communicate with each other. So I deal a lot with syntax and semantics of defining agent language so that they can interact with human. And he and his team at NASA since 2006 developed this metabolic rate advisor, which I'm going to tell you a little bit about the story. And I was very inspired because my dad has heart disease. He's lived with chronic disease for over a decade, 20 years. So I know the struggle of a patient. And I say, hey, this is what patient needs. And Bill got me connected with Anil and Professor Sergey, who has been specializing in small data, personalized machine learning using biosensors. But at that time, there wasn't yet commercially available wearables and biosensors because they were mainly working on, classified US government project, but they already had invented those methods using control theory and machine learning. And through my as a co-chairman for the symposium that I organized in Malaysia, I met with the Ministry of Health cardiologists, and they were the one who directed us further the specific features that current solutions in emerging markets, developed by medtech companies, global companies, that is not fulfilling the needs of the people and the patients here. And then I had all of the team. They are consultant practitioners, meaning they see patients in the clinic. They manage very high volume. I think in one of our centers, we get about 1,000 patients per day. Can you imagine? Such high volume, don't have so many cardiologists and resources. Now, what was it that we wanted to develop? In 2006, Bill and his team developed this metabolic rate advisor, and they use voice command, the concept of intelligent agent, mobile agent, where basically all these agents are automating some of the work practices and doing work on behalf of people as well as on behalf of other agents. You could think of it today as microservices on AWS cloud, but it's not quite like it, but it's similar to that concept. So this capability, the astronauts, they have to maintain their metabolic rate because they have to make sure that, they are fit enough to travel back to their habitat, so to speak, when they're exploring Mars. So basically, they have all these advanced biosensors, and all these agents are taking all these biosensors and accessing through the API hardware and predicting to the point that they can actually advise, which route should you take, so that when you arrive at your habitat, so that you can arrive at your habitat. And all of this interaction is doing through voice command. And that time, Alexa and Siri was not yet famous, and they were already doing this. So I was so impressed, and I said, wow, we should have this. That was 2012, but this was the ideal that I had, not yet going into hospital setting. That's where the socio-technical method came in. And the idea was that patient will have the wearable biosensors all the time. And then we will have an intelligent health agent that can, speak like a chatbot these days and advise patient what to do, alerts doctors and hospital call center. So, it's a basic remote monitoring and infrastructure at that time. Again, this was 2012, and the use of smartphone. So, but we didn't really have a domain application. I mean, I know my dad had heart disease. He has a coronary heart disease, but I didn't know specifically within which heart disease would this be most beneficial. So we were missing a little bit about the domain application at that time. So the journey hasn't been straightforward. Now, what we had done, since 2012, 2014, in 2018, we raised $67,000 US from Monash University, Malaysia. Very thankful to the strategic fund for our former president, Professor Andrew Walker. So we conducted a feasibility study, basically a retrospective clinical study collecting implantable device data, as well as patient admission data. And mind you, we had another challenge because COVID came in 2019. So we had to improvise every single thing, from protocol to human-centered computing approach, socio-technical system approach, to be virtually online. And it was a success. I am amazed we managed to do it. We managed to develop from scratch our back-end workflow agent technology. We modernized and miniaturized complex AI system and know-how that was developed in NASA to work on a mobile app. And we have a patent pending on that technology as well in the US and Malaysia. So throughout, using a human-centered computer approach, we actually identified the product fit, as opposed to a normal startup. When you think about it, they have an MVP, they soft launch, then they find a product fit. But we've done it because, we use a human-centered approach. So the team, the cardiologists and the patients were very much involved very early in the design. And we actually do it in a way that we educate them. So we have whenever we collect 5 data from the implant data, and then our machine learning scientist has an output, we will quickly have a review and walk them through. And it's very important because they also understand the limitation of technology with what they need, and they can also advise us on how to go about the complex healthcare system so that it can be used in practical for them, for their patients. And as a result, we also work with one of the former FDA Deputy Director, Mitch, which is through David's contact. And it was very interesting because, again, it resonates with what Rashida said, to think about the market, to think about regulatory process. And, we had to re-strategize about features like that is of low risk, thinking about patient safety. And we learned that it is very important to involve FDA very, very early before you do your product planning and pilot study, so that you don't have to repeat the trial elsewhere in terms of, cost saving. So that was a really exciting moment for the whole team. Now, this is what we wanted to do 2012. This is what we actually built in 2020. And again, we found out through socio-technical, methods that we require people to sit at the hospital call center, which was impossible to do, not in Malaysia. We need access to sophisticated device sensors, exactly like what Perry said. Some device manufacturers, they're not going to give you access to the raw data. Most often, what you're going to get is data from what is already computed. We need stable internet connections, so it has to work on wireless, because most of the patients who will use this are heart failure patients, and in our demographic, they're typically coming from lower socioeconomic background. And the reimbursement, if we were to develop, another biosensors wearables, is you have to think about the reimbursement model in that healthcare system, right? In Malaysia, it's very challenging for you to show that the government should pay on behalf of patient or subsidize a wearable that costs 2,000 or even 1,000, because we have a high volume of patient. And funding, you have to think about the cost of doing the research and translating it into an actual commercial product. Because if your funding goes up, then the cost of the product also goes up, and you want to make it accessible to a lot of people in this market. So at the end of the day, we scrap all that. What required is that we leverage on patients' own smart devices, to mean that even if they have a mobile, even if they have a smartphone, they can already benefit from our app. And we leverage on mobile app infrastructure, and we make our AI program to be able to compute on the edge. So this is gone, this is gone. And we chose, the doctor actually said, hey, this is applicable to heart failure because it has a very clear measurable outcome in terms of reimbursement from a healthcare perspective. And you have to show that it can reduce the risk of hospitalization and improve of quality of care, which you can actually capture and access that. So I think that's another point which is important to think about when you're going to healthcare, is the reimbursement healthcare system, right? I mean, who's gonna pay at the end of the day? What is it that what are the data that they need to see to be able to approve you for reimbursement? So basically what we're doing is creating a universal equitable access to health outcome, so that even if a hospital do not have a sophisticated hardware or infrastructure, they can still provide this. And to remotely automate some of the mundane tasks of, for example, sorting alerts and managing the alerts and communicating to patient by what we call, autonomous agent. And this is what our app looks like. It's very simple so that everyone can use it. So basically, our machine learning only needs about 56 kilobytes of data to compute on the device. It will work offline. That means, it's installed, embedded, and our machine learning becomes an agent itself. That means it's proactive. It tracks the heart status of patient, and one way not to get patients to feel, mundane tasks of every day putting their symptoms and vital sign is that whenever they track, like what Pari was saying, changes in the physical activity, which you can easily measure and get from phone accelerometer sensor data, you've prompt the patient and ask them to verify whether, are you experiencing symptom or not. And if they do, our agent starts to execute a set of clinical workflow, like how would you do in a clinic? If you have symptoms, okay, you take vital signs and then so forth. So the agent does it on behalf of the nurse. And the uniqueness is that our machine learning scientists had to really think out of the box, because we'll say, oh, sorry, this data we can't get for you. No, this is the reality. So they had to make it work that even if the vital signs recording is not real time, as in, when you're experiencing breathlessness, you're not able to capture that vital signs because you're outside the house or you don't have your fitness tracker. As long as you record within 24 hours, the machine learning will still be able to make good enough prediction. And if you have a fitness tracker, it can augment, so that means give a higher automated feedback. And if you have an implant, it can augment further and incorporate that data into the machine learning. And we actually have also an app, a web-based app for the doctors, where they're able to remotely intervene by changing management plan, which is drug dosage. So whatever that is changed. It is reflected on the patient app, and then the agents update their memory and belief, and then communicate with the patient of the new drug dosage. So this is just to show the back end, to say that we've actually implemented a workflow agent type of software. And this is our machine learning. It's a prototype right now. So interestingly, not only it can detect 7 to 10 days before unplanned hospital admission. This blue line actually represent the hospital admission. And this is only using implantable device data and majorly from one individual, so it's personalized learning, but it also can detect stable heart status. And that is the most interesting part from it, is that we can then actually, give new knowledge to doctors. What is it that the patient has been doing, or the environmental stressor that is keeping the heart status of that patient stable? So that will be also important to capture not only the unstable status, but also the stable status. So I'm trying to make sure that I keep on the time. So I think I have enough time here. So just going back a little bit here, our model does not use statistic. It uses, as I mentioned, it uses control theory, differential equation. And it's actually developed by Professor Sergey. So we treat the heart like a chaos system. And they have what they call an observer, but we use machine learning, basic, unsupervised learning, as well as we based our scientific principle of heart not on hemodynamics, which is what typically medical implants manufacturers tend to view when they're developing invasive implants, but we look at it from a homeostasis level, how the body needs to compensate in order to be able, walk and climb the stairs. And based on that scientific principle, that is how we model our machine learning. So yes, it can definitely work on the edge. Now, what we have learned from this long journey, because before, what we wanted to do, there was no digital health, people weren't yet really talking about it, is that often we start with an ideal view of how things should work. That's how, how we started as a team. And when we go into the real world, the world is often chaotic, like Rashida said, I truly love her talk. I've actually all of the speakers' talk because I can relate. It's messy, there's policy, there's security, there's psychology, it's multidisciplinary. And we have to bear in mind, not everyone is ready for transformation in a hospital, but keep to your vision, be practical. And I do find that the most useful skills is ethnography skill. So I actually offered to become an intern at the National Heart Institute for 1 year. I've been in a bypass surgery, did walk rounds with anesthesiologists, sit in cardiologist's room to really understand, a very big picture from management to treatment to payment, from patient perspective, from doctor's perspective, and how they all operate as a complex system. And I think that this kind of challenging environment actually forces you to be innovative and practical. And viewing, people like David and the cardiologists as partner rather than end users are very important, because that builds that teamwork, that shared value and vision. And it's very important to get them, be with you despite all the challenges. So we are at the point of incorporating Green Heart this week, in fact, and upgrading our prototype into a product. We've also received approval to pilot a prospective observational study to be used nationwide in Malaysia. And we're actively pitching for investment, and we've already recruited 2 developers. So very exciting times from us here at Malaysia. And I would like just to thank again for Chris to be organizing this, and to Monash University Malaysia leadership in supporting us. Without them, we wouldn't have come this far. Thank you.
Thank you very much, Naila. Obviously, not all of you know Naila's journey, but she's done a good job at articulating some of it. So it's really nice to see her having this outcome after what I know is a lot of work. Thank you very much to all our speakers. So we have some questions, some live questions still. If I could ask all our speakers to turn their cameras back on, please. I'm going to direct a couple first. I think there was a question from Richard that I sort of unintentionally made hide, probably in two parts. So, Suzanne, I'm going to ask you the second part of Richard's question. So how do you do post-deployment marketing and reviews? I think you sort of alluded to that a little bit. Can you talk about that, given you have a couple of large-scale apps in use? You're on...
yes, definitely. We're doing reviews. Sorry, I'm just trying to find the question.
It's gone into the answered bucket because I asked Richard a question in return.
Okay. Yes, we're doing reviews. I'm not sure what you meant with marketing. So we're speaking about our apps to healthcare providers, and the clinicians are presenting it at conferences. We have some publications of what we've done in different areas, obviously the co-design part, the whole development of the application, including patients and women with experience. We're including, the community. We have consumer engagement groups that we use during the development already to cover all those needs, and that's how we then also spread the words about the applications. And then we work closely with Monash Health, so the clinicians at Monash Health are a big important audience for the risk prediction tools and also the applications. We have some of the applications that are implemented into the Monash Health services that we're currently working on. So they are part of routine care and are introduced to the community through routine care. That's something we're working on currently. If that answers the question.
I think you've touched on it well. Thank you, Suzanne. So maybe, and this could go to anybody on the panel, how do you accommodate language and literacy and things like Aboriginal and Torres Strait Islander status in co-design of these systems? Any of our panelists can have a go at answering that.
I could give it a start, Chris. So I guess there are two aspects to this. One is ensuring that, as Chris said, having them included in the co-design process, which means as a R&D team, when we are selecting for participants to work with us, that we need to have that diversity and inclusion lens on in terms of selecting who we are working with. Now, having said that, in reality, it is super challenging because you're already trying to steal, borrow, beg of people's time in their lives to dedicate, like a half an hour to engage with you on something that may not be of immediate use to them. Okay, so that's already a big ask. So there's a bit of, beggars can't be choosers, to be, very blunt about that. But at the same time, if we do have that lens on, it will mean that we can hopefully connect with some of the community representatives or specific communities and go look out in those communities, meaning that hopefully we will be able to balance that out eventually. And to the other aspect of it, I guess, is in the design itself. And by that I mean the actual software design. And again, some of my other lovely panelists will be able to comment on these aspects in their various projects. But for me, for instance, we have really considered language in our design for our project, and to be able to provide the ability for people to select their language language, but also their dialect when they're selecting these services. So that's I guess, the advantage that technology can offer, and at a much, a sort of a fraction of a cost. However, again, caveat there is that it comes with the concerns around accuracy. So what we're looking at is, if we're trying to build a software app that also accommodates different languages, then ultimately the models that you're using for translation and so on need to be super accurate. And because it's in the medical context, it's probably best done in collaboration with an actual interpreter, so that they are overlooking that to be able to, confirm that what's being said is indeed what was intended. So those, I guess, are the two aspects of trying to, have a more inclusive team and design.
Thank you, Rashina. Naila or Parry, did you have any comments on this issue of incorporating diverse views and language and literacy and education into usage descriptions and users?
Well, for us, because in Malaysia we have Tamil speaking, Mandarin speaking, Malay speaking, and then the indigenous population. So we are lucky because again, like what Rashida says, we actually have a hospital, which is our pilot place to go in Sabah, who are the one who gives us access to these patients. So we actually do have a healthcare practitioner themselves who are part of our team to help us manage in the language translation when we're designing the app. So we actually discovered that we need someone still from a medical background, and someone who comes from that, that population, because they're the one who understands from a patient's perspective. So what we do is remotely, because again, I did this during COVID, is that I would sit in the Zoom, and then I would sit there to ask the doctor specific question I want the patient, and sometimes they will answer in Sabah dialect, and then we have the prototype mock-up design. And then the doctor will retranslate that and then ask me, Naila, is this what you mean? I say, yeah. So, our translator is a human translator, not yet quite fancy at the moment. But that's how we work around with it, Chris. Yeah. I mean, from my experience.
The same here, pretty much similar approaches. A new PhD student I have needs to work with a certain community, certain dialect and language, and we are using design thinking workshops with them and ideation with them, and also we use personas to represent them. And one interesting thing in the app prototype, it is for them, but we are including English as well, because with older people, sometimes they're a carer, a nurse, someone else that knows English. That was a very interesting point, that while you have their own language, you also need to consider maybe someone is with them that helping them with it. So bilingual kind of, so that's another consideration.
Thank you, Parry. It's really interesting, even thinking about working in hospitals with various healthcare professionals and trying to implement systems or design systems, that problem of access, Rashina. They want to be involved, and we know they should be involved, but actually getting them to do it because of their time, they're busy, it's actually really hard. It's not lack of awareness on anyone's part, it's just a mechanical problem. Look, there was a couple of other good questions that had some initial answers, but it looks like we've got some more. There we go. Okay. A question from Nadine. Nadine, can you see that, Naila and Rashina? It looks like it's addressed to you.
Yeah, I mean, Rashina can go first.
If you've read the question, which I'm trying to do now, Naila, feel free to go.
Okay, sure. So for us to prevent misunderstanding in requirements, we actually use what we call concept map. knowledge map. So, and we use persona as well, and we also use user story. It's a different, so in other words, we use different representation to get to take multiple requirements, multiple viewpoints of a requirement system, in kind of a way to go through with the stakeholders and make sure that from different angle, there isn't a misunderstanding. Do you see from where I'm coming? So it's not one type of, just an interview. We actually do the observation, the ethnography study. I actually record all the observation, and I ask the clinician to go through. Am I understanding your work practices or not? And then they fill in the blanks. They say, oh no, this is actually the nurse that will do this. This is not the person. Then we go to a more sophisticated level where we actually have a user story. And then we say, okay, imagine as a cardiologist, I want to see this in my feature, for example. And then we give a sample of how to answer, and then they answer it. The mock-up, we use Figma to quickly ideate this and show them the features is the part where you have to do it iteratively. And then after we use the user story, we also create persona. So it was interesting that we gave the persona to some of the nurses to imagine that there are patients when we couldn't get enough patients, right? And it actually helped them to understand as well from a patient's perspective, like, oh yeah, my patients typically complain when they come to the clinic and so forth. And we were able to actually capture that as well. So there are multiple levels. Requirements doesn't stop. It doesn't stop, right? You iterate and iterate, you find out more, you ask more, you validate more. It's a continuous process to ensure that you minimize the risk of misunderstanding in communicating the requirements. Whereas for the patient champion, right? Because we work closely in Sabah, and we're very fortunate. So they actually find patients who has personal motivations. I think this is where Rashida was saying that, we're taking patient time. So I think that personal motivation is very important. So we're lucky we found 2 patients who kind of like, okay, give me the app, I'll try it for a month, I tell you how it is. And one of the patients is actually from a software engineering background. So it's possible to, kind of like dig in, but you really need to work closely with the patient support group at the hospital. Yeah, I think that's the key thing for me. Yeah.
That was a super short, quick masterclass on everything that can be said. That was amazing, Nala. I really don't have any more to add. That sounds super comprehensive. Thanks.
And for any of you, there was a follow-up question. Where you've seen misunderstandings in requirements for any of you, what sort of costs can that result in? I don't think the question is just about money. It's about what happens when that goes wrong.
Yeah, I think there's an interesting, even as Nala was speaking, I was thinking about not just understanding the requirements well, but there's also this other angle of conflicting requirements, right? So what if you've got one user participant saying one thing and the other one saying sometimes diametrically opposite things? So I will I guess draw our attention back to that Venn diagram, the 3-way Venn diagram that I showed about the sweet spot. Is a lot of it comes down to what the users require, want versus need. And then on top of that, to marry that with the technical feasibility angle. So we have to consider that from that angle in terms of, all right, of the things that are being said, sometimes conflicting, which is in the best interest of implementing and which is technically possible. So sometimes considering the technical possibility, feasibility resolves that conflict because one may be possible and the other isn't. Simple as that. And the other angle, I think, is it might sound contradictory, but while user input is super important, there is also an element of where does innovation come from? Because it doesn't always come from the users or the participants, if I'm being brutally honest. It is a combination of what where the technology and the advancement is at, which oftentimes the tech team is more aware of than, say, the lay participant. But many a time it also comes from the lay participants who may not have the know-how, but will have the idea of what they want. And then you marry that with your know-how to come up with a super innovative way of dealing with it. Anyway, so that probably answered more than was asked, but hopefully answered a bit of what was asked.
Can I add a bit on that? I have a very good example. This happens. So I often find that misunderstanding occurs with the developers, not with the users, especially when you're building AI system. And mind you, we're trying to get them to build agents where we don't even teach in our units, multi-agent system. And these are undergraduate students, so, final year software engineering students. So there is a cost in terms of the work equity that you put in and the delay in launching a feature, for example. So for example, we lost a whole semester. That's why our prototype took 2 years, because it's done by students, but they did a fantastic job. It's because they did not clearly understand the concept of agent, right? And then what we mean by real time, simple things like what we mean by physical activity, getting that data, and then showing physical fitness level on the app, right? And they don't clarify requirements. Actually, our requirements engine, our software engineers should have better communication with others, right? And then we found out by the end of the semester that, oh, miss, after all this while, we misunderstood your requirements. So, oh my God. And that delayed us in our timeline. So it does have a cost to the product development. And I often think it actually comes between the developers when you're trying to talk about AI, machine learning. And I think that's where Monash, maybe we could have a unit for that for software engineers. Yeah.
This actually triggered a thought. Chris, can I quickly cover two quick things? So one is, what Naila said about the feedback from the developers. I think the shorter our iterations are, the better we have a chance to overcome any miscommunication and misunderstanding of requirements and fix it before it's too late. So agile sort of software development methodologies make a lot of sense in our space because it's so rapid and uncertain. And then the second point is, it was just a great connect back. Just realized Susan was speaking about Ask Because. So we've had a PhD student, Susan, who's actually done a case study on Ask Because. And we've been looking at empathy, which is super, relevant to this idea of why do we misunderstand requirements between the users and the developers. And this is exactly what she's studying. And her name is Hashini. And Hashini is looking at what role empathy plays in making sure we don't have those miscommunications.
Yeah, that's a super interesting project. There was something we worked on also with the student team last year. And many of those things came up that you're mentioning, Naila, and I just wanted to jump in as well. If in a real world project, having an agile development approach and doing very short iterations which isn't always possible in student projects in a unit. But yeah, very interesting. Yeah.
There's a technical question at the end there from Stephen. So just while you contemplate that, so do any of the products or projects discussed today use health data standards such as FHIR for interoperability? I'll let you just have a quick ponder of that. And if anyone wants to proceed to answer, please do. I'm going to give Stephen a link to a completely separate project I'm on. There's a web page about it, though, there, Stephen. We're certainly using FHIR for that. But did others want to comment on that from your different projects? I know Rashina's project is using WebRTC, which she mentioned. not so much a data standard, but potentially using the data channel in WebRTC. Any other comments from the panel?
We're looking into FIRE for future applications. The ones I mentioned today, they don't.
Yes. Very good. What about you, Naila? How's some of your data exchange working? What sort of approaches are you using?
Yeah, because we're not using electronic medical records for our prediction. We're just using device sensor data, like what Pari was mentioning, and patients self-reported. Yeah. So at the moment, no, but in the future, if it's integrated, definitely we have to look into that.
Well, it'll be using some standard. It's just that it's
yeah. If a hospital has an EMR, then obviously we have to integrate with their EMR.
Any other comments on that one, folks? No. Jennifer has asked a question there about innovation and financial benefit. Anyone want to tackle that? I've answered an initial stab at the question from Jennifer, but anyone else want to pick that one up?
Yes, I'm going to have to go to an actual teaching workshop, but students await, I cannot ignore.
Yeah.
But thank you so much for the opportunity and lovely chatting with everybody today. Thank you.
So Jennifer's question is relatable as well. Yes, it's that I'm not aware if there is a research that is doing that. I'm sure there are, but we have seen this ourselves when we're doing our project for Green Heart. Is we actually have to look into computational costs, of running the algorithm, maintaining on AWS, and what is the pricing that payers want to pay, that they feel that this is the value that the product gives. Because if we, risk too much investment in the beginning, when we've seen this in many of the hospitals, that at the end of the day, the end user are, the patients aren't able to use anymore that system because the hospital aren't able to continue with the maintenance in using that system in their hospital. Yeah. But I'm really not sure whether there is a research that looks into that, but I know that we are going through that process. Yeah.
I mean, I can comment a little from an EMR perspective. I mean, I did some talks recently to different groups of senior people about digital transformation and digital hospitals and the journey. And, finance people won't like to hear this, but I've seen hospitals constantly try and reduce the implementation of, say, an EMR to a financial input-output conversation to justify the investment. So just from a money point of view. So, we think we need to spend $30 million. So let us try and find $30 million or $10 million of savings to offset that. And then you end up in this bizarre thing where people tweak figures in a spreadsheet to optimize how much they're going to save. And yet it just seems a chasing the tail exercise. So an EMR, for instance, I don't think you should be trying to you have to find the money, don't get me wrong, but turning it into an ROI conversation purely around money is doomed to fail because that's not how they work. And, it's other things that you're doing it for. You're not doing it to save money. Sure, trying to attach a value to certain obvious things that will be improved. But I doubt you're ever going to get your money back in that sense. But touches a little bit on what Jennifer's asking, but in a slightly different area. Do any of the panel have other comments on Jennifer's question?
Yeah, maybe a comment for me. I think for those projects, it's important to also plan the budget to not just think about the development and the implementation in the first year, but also think ahead and secure funding to actually maintain it and run it on AWS.
Nice.
And plan some features that may come later with user feedback, again touching on the iterations that will certainly come once it's live. So that's probably a little bit more of a project planning perspective of, you know, having a bucket for year 2 and 3 to make sure you can maintain it and update it, and you don't just leave your users unsupported. It's
one of the challenges in doing this work in an R&D paradigm too, for instance. So the grant schemes don't want to hear about years 2, 3, 4, N, and what it takes to maintain the system. They just want to see a nice little thing at the end of their funded period, but we're not going to change that today. Look, I'm just going to, I'm conscious we're out of questions there, and we've got a couple of people dropping off. I'm just going to put up again this email address, which is my email address. If anybody has any follow-up questions for the panel afterwards, feel free to write to me. It probably just asks you to be quite clear on what you're asking and who you're asking it of, so I can easily forward it on. Before everybody heads off, I'd just like to, again, thank our speakers today. So thank you, Naila. Thank you, Suzanne. Thank you, Parry. Thank you, Rashina and Absentia. We didn't intend to have an all-female panel. There was no planning around that. It just dawned on me today that that's what we had. So that's a good thing. And I'd also like very much to thank our wonderful marketing and events team in FIT. So Heather and Ankit and others working in the background. Equally, if you want to hear about the Alliance for Digital Health at Monash, which you can see over my shoulder, you can reach out to me on that email address. And we will be running another 8 of these sessions on a whole range of topics, usually in the last week of the month as the year progresses. So with that, I will bring everything to a close, and thank you everybody again for your participation, panel and organisers and audience. Thank you very much and have a good evening.
Thank you, Chris and everyone.
Chris.
Thank you.
Thank you.
Bye.
See you soon.
Bye-bye.